Thank you, Dr. Teju. So, I know it's a busy evening, and I think now it's 1 hour sort of pro. So, I will probably highlight on the important aspects. So, I'm not going to teach you how to do a scan. So, I probably teach you the important aspects of point of view ultrasonography and when you have to use it in the clinical setting. And if you see this picture, which is a nice picture from the Google, you see it's scan probes everywhere on the body. So it's I would tell this is an extension to your examining hand. So as physicians or clinicians, you have the clinical skills. If you have this, so it will extend your diagnostic skills. Probably this will be the future that you will see in the clinical practice. So focus or focus ultrasound. So there are a lot of words in this para. But I want to highlight important words like focused. So it's a focused examination performed by a physician using an ultrasound, and it's an adjunct to the physical examination to recognize specific ultrasonic signs. And it represents a narrow list of potential diagnoses in a specific clinical setting. So those highlighted words are really important. What really mean by a focused ultrasonography? So there are several components of ultrasonography or echocardiography. So echo, which mainly deals with the heart. So there are several abbreviations used like FICE, which is focused intensive care echocardiography, and also some
FADE. So it's a focused assessment diagnostic echocardiography and lung ultrasound, imaging the lung, abdomen. So FAST. So the focused assessment of sonography in trauma. This came from trauma. So they used to scan the abdomen using the ultrasound to mainly detect fluid. And also vascular, especially in the intensive care setting, we use for vascular catheters, but also you can use to diagnose conditions like deep vein thrombosis in an appropriate clinical setting. So why it is important, especially in critical ill patients? It's a real-time assessment, and it guides therapeutic interventions, including volume resuscitation, instigation of vasoactive therapy, and or if you want to refer to a specialist, maybe a cardiac colleague, or maybe for a surgical intervention, so you can get a clue. And it's very quick and guides early treatment. And other advantages, it can be repeated. And it avoids exposure to ionizing radiation, and healthcare practitioners are not needed other than the performing physician, and it's easy to learn. So ultrasound tips, it integrates cross-section into structures, and the important thing is the fluid and solid organs conduct sounds, whereas air and bone do not conduct sound. So if you want to get an image, the ultrasound beam has to reflect back to the probe for you to get an image. So air and bone conducts that does not reflect. So coming into FICE, so focused intensive care echocardiography. So when we do a scan, echocardiography, we call it a focused echocardiography. So now when the echocardiography was practiced by the intensive care physician, they had no clue what to write after after the echocardiography. So there's a person who came up with certain tick boxes that you have to fulfill after you perform this focused echocardiography. So we'll be answering specific questions. Those are either yes or no. Is the LV function significantly impaired? Yes or no. Is the LV dilated? Is it yes or no? Is the RV dilated or severely impaired? Is there pericardial fluid? Is there evidence of hypovolemia, or is there pleural fluid? So after echocardiography, which includes the lung bases, we should be able to answer all these questions. And other comments can be made, and conclusion of the study should be related to the clinical significance of the findings. So I will explain with certain clinical scenarios. So I'll quickly go through this. I know you can't learn this by, by lecture, or you have to have the hands-on and do practice over time. So I'll just give you a highlight on the views, which I show you. So it will be important for you to understand what I'm showing you. So parasternal long, these are the views that we get in echocardiography. One is parasternal long axis view, parasternal short axis view, apical four-chamber view, and subcostal view, and the lung bases. So parasternal long axis view. Now, if you imagine, this is the view that you get with the parasternal long axis view. So the probe, the pointer is towards the the right clavicle, and you cut across the heart along this axis, and you see the right ventricle closest to the probe, and you see the left ventricle, which is down here, the left atrium, mitral valve, LVOT, and then the aorta, the aortic valve. So this is the basic view. Just have an idea. When you practice, you will get this image when you do more scans. So parasternal short axis view, where you cut across at 90 degrees to the parasternal long axis view. So what you have to do, turn the probe 90 degrees clockwise, where pointer is towards the left shoulder, where you can cut the heart at different levels. So you can cut at the base of the heart, or the papillary muscle level and apical level. So there are different levels. So what you see in the parasternal short axis view is something like this. Now these are the two papillary muscles. So this cross section is at the papillary muscle levels. You see circular left ventricle and sort of a bean-shaped right ventricle. And you see the anterior papillary muscle and the posterior papillary muscle. This view gives an idea of what's happening at the left ventricle, or what's the left ventricular function in the patient. So this is what I told you. You see at different levels, you see different structures. So this is at the aortic valve level. You see the aortic valve, left atrium, right atrium, tricuspid valve, RVOT, then the pulmonary artery. This we usually are not interested in, but this is at the papillary, the mitral valve level. You see the anterior mitral valve and the posterior mitral valve. And then if you go lower down, you see the papillary muscle level. And if you go further down, you see the apex. So this is sort of a regional presentation of the parasternal short axis view. Again, this is mainly for the cardiologist, where they divide the LV into anterior, inferior, then anterolateral, inferolateral. If you have the septums, you have the anteroseptum or inferoseptum. So this is how they go by the regional wall motion abnormalities. So this is, again, you see at the papillary muscle level. So the fourth view, the third view, which is the apical four-chamber view, where you see the probe is at the apex. So this is called the apical view, and you see the four chambers. So the pointer towards the left shoulder, and so what is closest to the probe is the apex. So in the apex, you see the left ventricle and the mitral valve, left atrium, right atrium, tricuspid valve, and the right ventricle. So this is a good view to assess the right ventricle. Subcostal view, which is very commonly used, especially in the emergency setting. when you have patients with trauma, you keep the probe in the subcostal region, where you keep the pointer towards the left shoulder, and you see the heart through the liver. If I show you, so this is the liver. So you see the heart through the liver. So what is closest to the liver is the right ventricle. Then you have the right atrium with the tricuspid valve, left ventricle, left atrium. So this is a good view. If you have a pericardial effusion, you might see the pericardial effusion in this area. Then comes to IVC, which where it's commonly, especially among the physicians, the clinicians, or the emergency practitioners, where they tend to assess the IVC. So IVC is, again, you see the right atrium and the IVC. So always when you get the IVC, always try to see the right atrium in the picture. Then it's very sure that this is the IVC, not the aorta. And you see the hepatic vein opening into the IVC. There are two ways you can get it. You can anti-clockwise turn the probe at the subcostal position. You turn it anti-clockwise, and then you might get the IVC. Or you keep the probe in the middle at the subcostal area and slide it towards the right side. Then when people see the IVC, they tend to see the IV collapsibility. So the normal tendency, this is a respiratory variation. In a normal spontaneously breathing person, the IVC collapses during inspiration and expands during expiration. So this collapsibility index, change in the IVC diameter, would give an idea whether the patient's fluid responsiveness. But this is being challenged, and there have been arguments whether it really predicts the volume responsiveness, or it basically predicts volume tolerance. So I start with a case just to highlight to you the importance of point of care echocardiography. This is a 45-year-old man with a history of hypertension admitted to hospital with acute abdominal pain, and CT showed a type B aortic dissection, and he was managed medically in the HDU, high dependence unit. However, he needed a TIVA, which is a stent repair, and during the procedure, he required 3 units of packed red cells and 3 units of FFP to control bleeding. He was intubated and admitted to the ICU after the procedure, and he was stable on noradrenaline with 0.5 mics per kg per minute with good gas exchange. With 40% of oxygen. After a few hours, patient developed hypotension. Now, this is a middle-aged man coming with type B dissection, had a stent repair with some bleeding, coming to the ICU with some vasopressor support, and a few hours later, patient develops hypotension. So this is the ECG that this patient has. And clearly what you can see in the ECG, there are definite ST elevations in 2-3 AVF with probable reciprocal changes in the anterior leads as well. Now, my question is, what would you do next? Are you going to refer this patient to a cardiologist for an urgent PCI? Or would you like to do a bedside echo, urgent blood transfusion, or thrombolysis? So there's a, you can answer using the polling system. And I'll give you 20 seconds to answer that. This was a real case scenario. Okay, right. So we decided to do a bedside echocardiography. So what would you see? So this is a parasternal long axis view. This is the left atrium, left ventricle, right ventricle, LVOT. And what you can see here, so if you see black, that is usually fluid. Now, if you have a fluid around the heart, that is most likely to be a pericardial effusion. So now we have a question. This patient who had a dissection, now he's dropping his blood pressure with an inferior ST elevations with a fluid or the pericardial fluid. So this is basically a case of a tamponade. So identifying a tamponade or a pericardial effusion, this is a good landmark. Now again the same view. This is the left atrium, left ventricle, and you see the fluid around the heart, and this is the descending aorta. If this fluid goes above the descending aorta, that's usually a pericardial effusion. But if it goes beyond or below, this is it's a pleural effusion. So you need to differentiate whether it's a pericardial effusion. Sometimes you might mistake for a pleural effusion as a pericardial effusion. And we went on to scan the inferior vena
can
cava.
falsely reassure a clinician to believe that a patient is adequately resuscitated. This line of reasoning misses critical points about IVCU.
Right. So you see the IVC is plethoric and it's non-collapsing. So again, this is it's a subcostal view showing a diastolic artery collapse with a significant pericardial effusion around the heart. Now see, this is a diastolic artery collapse indicates that probably this patient is going to a tamponade effect. So, and this again, a view of a pericardial effusion. You see the heart, this is apical four-chamber view. Heart is floating around this fluid. Now you see there's a lot of fluid in the pericardial sac. So it's most likely to be a chronic pericardial effusion. And also you say floating particles. So it's most likely to be a chronic pericardial effusion. This effect, now you see the floating heart, this is the reason that you get electrical alternance in the ECG. So echo signs of tamponade. So you get artery collapse, systolic artery collapse and a diastolic artery collapse, and a plethoric non-collapsing IVC. Now, if you have referred this patient to a cardiologist, they would have probably done the same thing. They have done an echo and see what's going on, and would have changed the management. If you have thrombolized, it's a disaster. And there's no real indication for a PCI as well. So echo did the trick. So patient underwent emergency thoracotomy, which is the treatment, and repair and returned back to the ICU, and he recovered well. His hemodynamics improved, and all the drains were removed by the 5th day, and he was successfully extubated on day 7. On day 8, he started developing temperature with 38.2, and septic screen was sent, antibiotics were started. So now he recovered from his tamponade, coming back to the ICU, extubated, now he's spiking fever. His heart rate goes up to 110, mean arterial pressure is around 55, central venous pressure around 8, lactate is 5.6, which is elevated, saturating at 92% on 40% of oxygen. So he was resuscitated with fluids, quite a significant amount of fluids, and these are the readings that you still see on the monitor. So he's still tachycardic, saturations are all right, but he's still hypotensive. What would you do next to improve the hemodynamics? So again, polling is open, so you can answer. Are you going to start noradrenaline infusion? So are you going to give further fluid bolus? Are you going to do an echo? Or are you going to do a chest X-ray? Right. Can I have the results if they have responded? Right. I can't see that on my screen, but I would like to know what the main answer is.
81% bedside USS echo.
Okay. So you are basically now we probably know this lecture is on echocardiography and ultrasound scan. So probably you think it's the answer. Yeah, that's correct. So what we did was an echocardiography. You see, this is a parasternal long axis view. What do you see here? This is called a hyperdynamic heart. So is patient tachycardic? Patient tachycardic, and you see the left ventricular muscles kiss each other. So this is called the kissing sign. So what does it mean? Patient needs further fluids. So your noradrenaline may not be the appropriate choice. So patient still will be fluid responsive. Again, you see the parasternal short axis view. You see clearly the papillary muscles kissing each other. So it's called the kissing papillary sign. And you see an empty left ventricle, which is sort of contracting vigorously to eject blood. So this patient definitely going to be fluid responsive. So then further going into inferior vena cava, so if you see the inferior vena cava, you classically see the IVC classically collapsing. So definitely now with all these images, you can tell that the patient is going to be fluid responsive. Now I would like to tell something about assessing IVC, which is a highly debatable topic when it comes to fluid responsiveness. As I told you, you see the right atrium and the IVC, and you see the hepatic veins. So now there are various studies done at assessing the IVC diameter and the collapsibility, but there are in the methodology, so they have taken the diameter at different levels. So the recommendation is, if you want to get the diameter, so because if someone else does it, they do at the same level. So at least 3 centimeters from the right atrial IVC junction, or at least 2.5 centimeters from the hepatic vein and IVC junction. So when you repeat it, you can reassess the IVC diameter. Now, these are numbers which we don't need to remember. It tells the IVC diameter and the respiratory collapsibility will tell you the CVP. But on the other hand, do we really need to know the CVP? Because CVP doesn't tell you whether your circulatory blood volume, and CVP does not really tell you whether you are going to be fluid responsive. So I've seen a lot of people measuring CVP and looking at the number, they tend to give fluids. But CVP has, in many studies, have shown that the number or even the change in the number does not predict whether the patient is going to be fluid responsive or not. Right. So then now this patient, so clinical picture is most likely to be sepsis with the spiking fever, hypotensive. So you know the treatment now we are going to give, whether we are going to give fluid or vasopressors with antibiotics on top of that. And we try to find out where this fever is coming from. So we scan the lung, and you see, so just to orientate you all, so this is the liver down here, and this area is the diaphragm, and you can see something very similar to liver here in the lung fields. So this is something like a hepatization. So this is a consolidation. So you probably know this patient is the focus of sepsis is the probably a hospital-acquired pneumonia because he was in the ICU. So you know your focus. So it's easy to guide the treatment. and you know what therapy you are going to give. And you can basically adjust your antimicrobial therapy as well. This is another scan just to show again the liver. You see the consolidated lung here. These tiny white dots are trapped air, and this black is fluid. So you see a pleural effusion here. Again, another picture showing a enlarging pleural effusion with a collapsed consolidation on the lung base, and here the diaphragm with the liver here. And this is also important when you want to tap a pleural effusion, you know where you're going to hit. Sometimes you might, if you blindly tap, you might hit the lung because the lung is moving. Then we further went down to scan the liver and the kidney. So just to see whether there's evidence of free fluid in the abdomen, or even for that, whether there has hydronephrosis, which will tell you this patient may be having evidence of ascending a UTI. So when it comes to scanning of the abdomen, you see in the previous scan, you can see the liver and the kidney. And here you see the spleen and the kidney. Again, in the abdominal scans, we mainly look whether there's free fluid or whether there's evidence of infection in the kidney, especially in the intensive care setting. So now, treated the sepsis, patient gradually improved as his fever, WBC, CRP came down and oxygen was weaned off. On day 10 of the ICU, he developed sudden onset shortness of breath with hypotension. He's now tachycardic, again hypotensive. CVP is around 16, lactate is 4, which is elevated. Chest X-ray slightly reduced air entry in the base. This is the ECG. And what is the likely cause for the deterioration? Is it sepsis again, or whether it's an acute coronary event? Is it pulmonary embolism, or is it bleeding? And again, there's polling, so you can answer your question. This is the ECG if you want to see again. Right. Can I know the answers?
90% pulmonary embolism and 9% sepsis and 4% bleeding.
Okay, right. So this is what we did. So this is a short axis view of the LV here and the RV. So this tells you the cause for the hypotension. You see, now usually the left ventricle is circular, and the right ventricle is sort of a bean shape. Now you see the septum is flattened. So this is like a D-shaped septum. So what does it mean? There's a right ventricular pressure overload. There's a right ventricular pressure overload minimizing the left ventricular filling. So until proven otherwise, if you see this, given the clinical picture, suspect whether there's something going on the right side of the heart. And this is a parasternal, this is a apical 4-chamber view. Left ventricle, left atrium, right ventricle. So the abnormality, what you can see here is the right ventricle is enlarged. Now usually the size of the left ventricle is 1.6 to 1, or the right ventricle should be less than 2/3 of the left ventricle diameter. Now you know right ventricle is enlarged. Now you see a sign here. Now usually the apex is formed by the left ventricle. Now when you have a dysfunctioning right ventricle and the right ventricle contracts vigorously. So therefore, this is called the McConnell sign. So this is seen in, especially in cases of pulmonary embolism. And you see, this is the tricuspid valve. You see the motion of the tricuspid valve, which is very, very less. And this is the TR jet that you see associated with dilatation of the right ventricle. And this is what we call the TAPSE, tricuspid positional systolic excursion. Now, the left ventricle contracts differently to the right ventricle, where the right ventricle contracts on its long axis. So you check the movement of the tricuspid annulus. So if it is less than 1.6, you say there's right ventricle systolic dysfunction. And if it is more than that, you tend to say, okay, your right ventricle systolic function is fairly all right. So I don't have time to show you how to measure it. And further, we went and assessed the IVC, which is plethoric and non-collapsing. So with the given clinical picture, dilated RV pressure overload, dilated IVC, in a patient with hypotension who's likely to who's been prolonged had prolonged stay, especially immobilized, it's very likely this is going to be a massive pulmonary embolism. And further went and scanned the deep veins. So this is the femoral vein, the femoral artery. You see a large clot in the femoral vein. So you know the source also. So this is very likely that the patient has pulmonary embolism, probably due to this DVT. This is a lung scan. You see a defect now. This is the visceral pleura and the parietal pleura, and you see a defect in the visceral pleura. So this is a pulmonary infarction. So you can so there are a lot of things that if you scan certain areas, you can tell what's going on. So pulmonary embolism on echo. So diagnosis of pulmonary embolism on echo, sensitivity and specificity is low if you don't have a massive M. So don't ask for an echo if the patient's blood pressure is stable. Go for a CTPA. But if the patient is hypotensive and you have a high degree of clinical suspicion, you can ask for an echo to see those signs of major pulmonary embolism. So massive pulmonary embolism, look for an RV strain, dilated right chamber more than the left, D-shaped LV, which I showed you with a flattened septum. Sometimes it could be paradoxical, non-collapsing IVC, significant tricuspid regurgitation, reduced movement of the tricuspid annulus. Sometimes you can see the main pulmonary artery clot also if you scan the parasternal long axis view. If you get the main pulmonary artery view, which is not included in the FICE. And of course, if you do a vascular scan, you might even diagnose DVT. So that's how the case 1 went. Case 2, a 70-year-old woman presents to the emergency department with increasing shortness of breath past day. She has a history of COPD, congestive cardiac failure, hypertension, and hyperlipidemia. On arrival, she's breathing rapidly, she's tachypneic, and using all her accessory muscles. Her heart rate is 115, blood pressure is all right, temperature is 37.5, saturation is 89 on 4 liters of nasal cannula. You perform a rapid physical examination, but you still aren't sure exactly what is causing her dyspnea. So there might have been an elevated JV, but her neck isn't easy to examine, especially in emergency situations. It's very difficult to sometimes see, examine the neck veins. The lung sounds a little wheezy, but there were probably some fine crackles as well, and you were waiting for the chest X-ray. Your resident asked if lung ultrasound might help diagnose pulmonary edema. So you have a clinical suspicion of pulmonary edema. Would lung ultrasound show that? So critical care ultrasonography in acute respiratory failure. If you want to scan lung is an aerated structure. So as I told you, air is an enemy to ultrasound. So all these interpretations that you see with the lung ultrasound are from artifacts. So you might have heard a lot of lines, A lines, B lines. So all these are artifacts. So depending on the nature of the artifacts, they interpret what's going on in the lung. So you might see A lines, B lines, sometimes You might see the consolidated lungs, pleural effusions, right? You see the lung sliding, pleural sliding. There are a lot of things that you can assess by using a lung ultrasound. So I'm not going to elaborate how to do them, the lung ultrasound. So these are some of the things that you might see. So this is the pleura, the blue line, and the reflection of the line you see in the monitor. Those are called the A lines. So these are normal. So it's a reflection. And if you see, these are called comet tails or B lines, extending from the pleura, going down towards the mediastinum. So sometimes you might see several B lines in a patient, but if you have more sort of frequent B lines or more confluent B lines, that means there's fluid in either in the interstitium or in the alveolar. And as I told you, maybe you might see consolidations. And also sometimes it might help you to diagnose certain things like pneumothorax. There are a lot of things that you can do using ultrasound of the lung. So this systematic review and meta-analysis of point-of-care ultrasonography in diagnosis of acute cardiogenic pulmonary edema in patients presenting with acute dyspnea. This is what our patient had. They identified 7 studies that included a total of 1,075 patients. Sensitivity of B lines of a point-of-care ultrasonography to diagnose acute pulmonary edema was quite high. So it was ranging around, close to 94%. Specificity also quite high. So it's a really good tool if you have this. But the limitation, there is no standardized threshold for diagnosis. How many B lines you have to tell that this patient has pulmonary edema? So you know fluid B lines or confluent B lines, you know there's fluid. And also patient demographics or ultrasound training of provider, and this would lead to heterogeneity. So different scanning techniques, and also the scanner, depending on the scanner, you might have heterogeneity among the studies. So study conclusion was B-line on ultrasound can confirm the diagnosis when the pre-test probability of the disease is high or low. So if you have a high degree of clinical suspicion, pre-test probability, you can do the scan and see whether it tallies with your clinical diagnosis. You may not need to wait for a chest X-ray. Again, diagnosing acute heart failure in the emergency department. In this review, what they conclude was bedside ultrasound. If you combine with the lung ultrasound and the echocardiography, which is very valuable in excluding a patient with cardiogenic pulmonary edema compared to other tests. So I'll just move on to Efast. This is extended FAST. So FAST is focused assessment of with sonography for trauma. This is mainly came up from the trauma setting. They looked at the heart, right upper quadrant, left upper quadrant, and pelvis. And they extended that scan into the chest to look for pleural fluid and whether there's evidence of a pneumothorax. So these are the things that they would expect if a patient with trauma comes to the emergency department. So key questions are, is there free fluid present in the pericardial space, in the peritoneal space, or in the pleural space? And they extended it to the lungs to exclude whether there's a pneumothorax. So I'm not going to tell you how to do this. So different probe positions. This is mainly look at the heart, left upper quadrant, right upper quadrant, and the pelvis. And this extended into the chest to look at the pneumothorax. So this is how you scan for the subcostal view to look at whether there's pericardial fluid, looking at the heart through the liver, which I showed. And this is to assess the right upper quadrant, the hepatorenal recess, again, to see whether there's fluid here, especially in the trauma setting. Again, on the left side, you see the spleen and the kidney. So whether there's fluid in between the spleen and the kidney. Pelvis, again, pelvic free fluid, and you can sometimes mistaken for the bladder. Sometimes you might see the catheter bulb in the bladder. So this is where you can scan for pneumothorax. You can scan it down to see certain signs of pneumothorax, and which is very sensitive. So this is, so black is usually fluid. So you see the liver and the kidney. So there's some fluid in between the liver and kidney. So in a trauma setting, this is probably intra-abdominal bleeding. So they have made certain protocols. This is one, rush protocol. So looked at the cardiac status, assessing pericardial sac for tamponade, LV function, RV size and the function for evidence of pulmonary embolism, looking at the inferior vena cava and the lungs for collapsibility, pneumothorax, and abdomen for free fluid, and also extended into looking at the aorta for, especially for dissection, and veins for looking at the deep vein thrombosis. Now you see how much information you can get just by getting a proper focused ultrasonography. So take home messages from my lecture. Ultrasonography in a critical ill is basically an extension to your examining hand. It's a valuable tool. But always use the clinical setting and always use the stethoscope before you use the ultrasound, because then the diagnostic accuracy will be very high. Always use when it's clinically indicated. Don't just go and scan everyone. And always relate your findings to the clinical context of the patient. Do not over or under interpret results. And do not replace formal echocardiography or radiology, because this is a point of care ultrasonography. Always refer to the expert when you are in doubt, because you make a decision on a doubtful finding that is not appropriate. Thank you.
Thank you, Dilshan, for that very informative and elaborative teaching. I think this is the next step our generation has to look forward for. And since there are no questions came, maybe because of the power failure that we are having at the moment in the country or this area, I would like to ask from you one question, Dilshan. Now, what is the place of 2D echocardiography, bedside echocardiography in acute valvular heart disease, say acute MR, acute AR? Is there any place for bedside echocardiography?
So, so if you consider a patient with acute MR or an acute AR, so this patient would be, the clinical scenario would be then cardiogenic shock or with a pulmonary edema. So in focused echocardiography, I told you there are several questions that we have to answer. What is the LV function? Is the LV dilated? What is the volume status? With the lung bases, and whether there's pericardial fluid. So none of these questions will answer valvular lesions, but it will tell you this patient may be in cardiogenic shock with a poor LV function, with the florid B lines on the lungs. So in that sort of a situation, what we are going to, this patient is probably having a cardiogenic shock, not any other shock. So then you have a doubt if, so we are not going to assess the valves or any regurgitant murmurs or stenosis. So then if you have a doubt, you go by the other findings such as ECGs, whether you exclude any acute con events. Then you, if you think something, then you might listen, you might hear a valvular lesion, then you may probably get a proper echocardiography from the proper expert. But in that setting, suppose the patient is pulmonary edema, for your management, patient be tachypnic. You don't know why the patient is tachypnic. Whether the patient has a pneumonia, whether the patient has a metabolic acidosis, patient is tachypnic, or whether the patient is probably tachypnic because the patient is cardiogenic shock with a pulmonary edema. So it will help you to stabilize the patient and get appropriate treatment at that site.
Okay, thank you. Now, practically, we have ultrasound machines in almost all our wards because we are scanning for dengue fever patients, for dengue hemolytic fever. Now, if the machine hasn't got a cardiac probe, what is your opinion if someone wants to do echo with the abdominal probe? Would you recommend, can we get any sono signs from that still?
Yeah, so idea would be the cardiac probe, phase stereo probe. But if you use the curvilinear probe, you can get the views of the subcostal views. So that's what you use, especially in the trauma setting. You quickly scan for the heart using the subcostal view, using the curvilinear probe. If you have a thin person, sometimes even the curvilinear probe might get a view, but you can't guarantee. If you can try, you might try and see whether you can get the view. So most important thing is to get the view. If you have a view, yes, you can interpret it. But if you don't have a view, don't interpret.
And one more question, Dilshan. Now, in this COVID situation, we have mostly alveolar damage rather than, typical consultation like picture. Do we have any, now, initially they did CTs, then chest X-rays. Do we have any evidence or any literature coming? Anyone has done ultrasound test and found anything different for these COVID patients? Anything to identify with regard to that?
Yeah, I think there's a lot of interest on ultrasound on COVID pneumonias because because you don't have to transfer the patient for a CT, and sometimes portable X-ray would be difficult sometimes to get. But if you have this portable scanner where you might see certain changes that would suggest COVID, so that would be the ideal, isn't it? But I'm not sure what exactly the specific parameters or the specific science that will tell this probably a COVID pneumonia. But I know that there's a lot of interest on using point of care ultrasound on the chest, using sort of a portable ultrasounds, that you have handheld ultrasounds. Yeah, you don't have the large machine, you can have the handheld ultrasound, which may give information, but I'm not sure the exact features which will tell on whether this patient, the probability of having COVID pneumonia or not.
Okay, thank you. Any other questions from the attendees? It's open for question now. Okay, thank you, Dilshan. So that we have come for the end, to the end of the teaching capsule today, point of care ultrasound. So may I invite Dr. Dilshan to come and receive the token of appreciation from Ceylon College of Physicians. Thank you, Dilshan. Okay, thank you. With that, we end this teaching capsule for today. Thank you.